Assalamu alaikum wa rahmatullahi wa barakatuhu. Welcome to the channel of Stand Medical Notes. So this will be the last video of the ECG series. So I think it is totally 8 videos, 8 to 9 videos it will be there. So by this, after the at the end what do you call? So by this video we end the topic of ECG series, and the next video will be on the different topic. So let's begin this last video with the name of Almighty. So as you are seeing here, the topic is other critical ECG diagnosis. So we can divide it 1, 2, 3. Effects of electrolyte disturbances, effect of autonomic tone, okay, stress testing and all is there. So we'll look at those ECGs which are critical. Okay. So first of all, these are very common. Effect of electrolyte disturbances. In that, the potassium and calcium, these two electrolyte disturbances are very common. So one by one we will discuss hyper hypo. Okay. So number one is hyperkalemia. So this is the electrolyte disturbance, and this is the mechanism, and this is the early ECG change, and this is the progressive change, initial earliest change. So when there is hyperkalemia, the potassium concentration is raised outside. So what happens with that? So understand the concept. So mainly there are the electrolytes which are involved in maintaining the basement membrane potential of cardiac muscle are sodium, potassium, calcium. These three are the main electrolytes which control the cardiac membrane potential. Okay, and in these three, the most important concentration, the most important electrolyte, great electrolyte, is the potassium. The potassium plays a very important role in maintaining the resting membrane potential of the cardiac muscle. So this has some the outside potassium, if this is outside of the cell, and if this is the inside of cell. So here will be some potassium here, but remember the inside potassium will be more than the outside potassium. Okay, but there will be some gradient, there will be difference between these two, outside potassium and inside potassium. Okay, that gradient maintains a basement membrane potential of minus 90 millivolts. So if I take it like this, remember it, this is at this point, minus 90 millivolts. Okay, so what happens is when there is hyperkalemia, outside potassium is increasing. Okay, so when there is hyperkalemia, this negative potential, this will move towards minus 70 millivolts. So when there is increased potassium concentration, the cell membrane potential, for example, it moves from minus 90 to minus 70 millivolts. Why it is like that? So the gradient is not maintained, so the gradient is lost now. So the gradient will take equilibrium at a new potential, and that potential will be compared to this minus 90, this minus 70 is more positive, no? So as you move from minus to 0, we are moving from positive side. Okay, and if you are moving from 0 to minus 90, minus 100, minus 110, like that, we are moving from a negative side. That means the inside of the cell is becoming somewhat positive when compared to the outside. That means the inside of the cell is becoming somewhat positive compared to the outside. So that's why I have marked this minus 90 at the lower level and minus 70 at the higher level. That means the cell is getting slightly depolarized at the basement membrane only, minus 70. So that means the cell is easy to depolarize now compared to previous. Easy to depolarize. So the impulse now, if you were giving impulse of 20, for example, now it may require impulse of 15, less impulse, because it is slightly depolarized due to this hyperkalemic stage. Okay, the basement membrane potential will move from minus 90 to minus 70, because in hyperkalemia there is raised potassium now. There is raised potassium. Okay, raised potassium inside the cell. raise potassium inside the cell. That's why the cell membrane potential is moving from -90 to -70 because of raised potassium inside the cell. Okay, but the thing which is problematic at this point is when this potential moves from this to this, the sodium channels get some sodium channels get deactivated. Now you remember that sodium channels play a very vital role in the zeroth phase from the base with the first spike. When you see here, this first spike is due to sodium only. So the sodium channels get deactivated. So this is happening. Okay, so because they are not set at this -70 membrane potential. So because of increased hyperkalemia, the potassium concentration inside the cell is increased. Because of that, the membrane potential moves from less negative to more negative to less negative side. That means it is slightly depolarized. At this membrane potential, some of the sodium channels are deactivated because they are set up at this membrane potential, meaning -70. Because of this deactivation of some channels, sodium channels, there will be delayed depolarization. This is the important point, because sodium channels play a very important role in the depolarization, because some sodium channels are getting deactivated at this what do you call basement membrane. So you are the depolarization is getting prolonged, depolarization getting in prolonged. At the same time, when the cell repolarizes. So if I remove this all thing, so this is the cell. One thing I want to say, this is -90 millivolt and this is -70 millivolt. Same time, repolarization means getting the potential from here to up to -90, getting the getting back the membrane potential to -90. That is depolarization. But when there is hyperpolarization, repolarization will be faster. See here. Now it doesn't have to go to -90. Sorry. Now it doesn't have to go to -90. It has to go to -70. So that is earlier to reach. No, this is late to reach. So repolarization will be early. Repolarization will be early and depolarization will be prolonged. Repolarization will be early. That's what here it is there. Increased depolarization means increased duration of depolarization. Increased duration of depolarization. And repolarization is decreased arrow means decreased duration of repolarization. So because of that, you will get these changes. Okay, understood the concept? This is the concept behind hyperkalemic changes. Now, what will happen then? What will happen then? So first change you will see is the tall narrow peak T waves. That is because of rapid repolarization. Okay, so you will see tall T waves in precordial leads. It will be, and the base will be narrow and they will be pointed. And this you will, and they'll be diffuse. Okay, this will be more than 5 mm in limb leads and more than 10 mm in precordial leads, means chest leads. That is tall P waves. That is the first change. Okay, the ventricles will be repolarizing very much early. That's why the width of the Q wave is decreased. The base will become narrow. So more the base, more the time taken. Less the base, less the time taken. Okay, so this is the first change. So now if the hyperkalemia progresses, what will happen? The atria will depolarize slowly. Meaning the P wave will widen and PR interval will widen. Okay, so that is the next change. So the atria will be like this. Okay, and the PR interval will be prolonged. Next, if the still hyperkalemia, if it progresses, then what will happen? The depolarization in the ventricles will prolong. That's why there is prolongation of QRS complex more than 3 small squares. There is prolongation of QRS complex. Now you just touch with this. Okay, this is the way. So first there is early repolarization of ventricles that causes tall T waves. Second, there will be delayed depolarization of atria that causes prolonged PR interval. And then there will be delayed depolarization of the ventricles that causes increased QRS width. And if still the hyperkalemia persists, if it is severe, then you will see, so number 1 you will see this one, number 2 this, number 3 this, then number 4 is sine wave pattern. This is sine wave means you sine, no, like this. You see the sign. So it will be like this, and this is a phase. This is known as sine wave pattern. Anytime the patient can enter into asystole. Anytime the patient can enter into asystole. So that is the funda behind this hyperkalemia. So I've explained this. Okay. Now, what is the funda behind hypokalemia? Now, again we will draw the cell. So if this is the cell, cardiac cell, cardiac myocyte. Okay. So now what will happen, because of hypokalemia, inside will become more negative. From, for example, if it is, this is minus 90, because there are less potassium, the concentration of potassium is decreased, positive ions is decreased, hypokalemia, the inside of the cell will become more negative. For example, it is minus 10 millivolt. So this seems to be like the cell will be difficult to depolarize. The cell will need more impulse to depolarize, but the book says that the effect will be more on the repolarization. It is difficult to depolarize. It will seem like, because see, minus 110 if you want to bring to more positive side, you will require more impulse, but book says the effect will be more on the repolarization. So minus 90 will be early to repolarize, but if you go to minus 10, then the duration of repolarization is prolonged. Duration of repolarization is prolonged. So the whole picture will be because of this increased duration of repolarization. So what will be the picture? So the early change which you will see is ventricles will depolarize. So I said no. So width will decrease. If width decreases, then that means duration is repolarization is fast. So opposite to that, width of the T wave is increasing and the height of the T wave is decreasing. That means the duration of repolarization is increased. So you will see flattened T waves, okay, and prominent U waves. What these U wave represent? U wave represent the repolarization of Purkinje fibers. Okay, repolarization of Purkinje fibers and papillary muscles. So in normal ECG you are not able to appreciate because the repolarization is somewhat fast comparatively, but because your repolarization is prolonged, you are able to see the repolarization of papillary muscles and Purkinje fibers. That's why you will see a prominent U wave in case of hypokalemia. So these two will be the earliest sign. So broad and flattened T waves and prominent U waves. Then next, what will happen? So there will be decreased duration of ST segment. ST segment will prolong. So QT interval will also prolong. QT interval prolongation you will see. Then PR interval prolongation will be there. Nothing but the repolarization is prolonged. PR interval is nothing but the electrical activity in the atria. QT interval is nothing but the QT interval is nothing but the electrical activity of ventricles. So everything will be increased. See, so PR interval will be increased because of delayed repolarization of atria, and ST segment duration will decrease because of ST segment duration will be decreased. Okay, but QR interval will be increased because of increased duration of increased duration of QT interval. So as I said QR, it is not here. QT interval, tongue slip. QT interval is increased. So that means because of increased duration of repolarization of the ventricles. That is the concept behind that. Okay. So the main thing, remember this first thing which is going to happen, that was the concept. So prominent U waves and flattened T waves. That is the first thing. Second, you will see increased PR interval and decreased QT interval. Remember this one, QT interval. And in severe cases, you can see increased QRS width also. Okay. That's about the changes in hypokalemia. Now coming to the concept behind changes in hyper and hypocalcemia. So remember the membrane potential, this curve, action potential of cardiac muscle. So this is 0th phase, this is phase 4, this is 1, this is 2, and this is 3. Okay, this phase is known as the plateau phase. So if you remember the physiology, two ions play a role here, the calcium ions and the potassium ions. Calcium ions will enter the cell and they want to depolarize the cell. Potassium ion will exit the cell and they want to repolarize the cell. Okay, so there will be fight between calcium and potassium in this plateau phase. So what happens when there is increased potassium? When there is increased potassium, more and more calcium will enter the cell. So this plateau phase will prolong. What will happen when there is Hypercalcemia, the plateau phase is getting prolonged. Sorry, I said wrong. The plateau phase will getting shortened. The plateau phase will get shortened. The plateau phase will get shortened because why? Because the plateau phase will get shortened when there is this plateau phase will get shortened. This plateau phase will become short. It will be like this. So when the plateau phase become shortened, so this shortens the total QT interval. Remember one, just for remembrance. So the concentration of calcium is inversely proportional to the QT interval. Concentration of calcium is inversely proportional to the QT interval. Concentration of calcium will be inversely proportional to the QT interval. So calcium, okay, that's how you remember. There is decreased duration of repolarization. Phase 2 shortening will be there. That is nothing but plateau phase will be shortened because of hypercalcemia. Why that is happening? Why the plateau phase is getting short? So outside there will be potassium. Potassium will move outside and calcium will enter inside. When there is hypercalcemia, the cell will have calcium inside it. Okay, I will just explain like this. When there is hypercalcemia, the intracellular calcium will increase. So the outside calcium, because of osmosis, if you remember, the calcium gradient is lost here. Because of increased calcium concentration in the cell, the calcium, the entry of calcium becomes difficult inside the cell. That's why the plateau phase is shortened. Okay, and repolarization duration will be shortened. That's why there is shortening of QT interval in hypercalcemia. When there is hypocalcemia, there is decreased calcium concentration in the cell, and outside calcium is easy to enter here. That causes prolongation of the plateau phase, and when the plateau phase is prolonged, the repolarization is prolonged, and there is that is causing prolongation of total QT interval. Okay, just it is the play of what do you call QT interval. When there is increased calcium, there is decreased QT interval. When there is decreased calcium, there is increased total QT interval, and that is because of plateau phase, which is responsible for the duration of repolarization. Now we will see the ECGs. See here. So this is mild to moderate hyperkalemia. You can see tall tented T waves with short base. Okay, short base without any ST segment. This is V2 lead, no? This is V2 lead. So to say it as ST segment deviation, it should be more than 2 mm. It is not more than 2 mm. It is like a early repolarization pattern like thing. Okay, type 1. Okay, but okay, here you can see tall T waves, tall peak T waves with narrow base. That is the early change in hyperkalemia. In severe hyperkalemia, so you can see dampening or flattening of the P wave and then widening of the QRS complex, and still you can see tall T waves. Okay, I will come to this one. You should differentiate this with you should differentiate this with tricyclic antidepressant toxicity. How you will differentiate? How will you differentiate? By tachycardia. That is only one thing you can differentiate, tachycardia. Okay, because tricyclic antidepressant toxicity will have the same ECG like this, but if you calculate the rate, it is approximately 100 beats per minute. Okay, 100 or I think yes, it is approximately 100 only. Okay, so that is the changes in. So first there will be T wave, tall T waves, then flattening of P waves, then prolongation of PR interval, then prolongation QRS width will increase. Then in severe cases you will have this sine wave pattern, and if it not treated, it will go into asystole. One point to remember in hyperkalemia or hypokalemia is, so ECG changes can occur at mild hypokalemia also. That's why it doesn't mean that if the patient has mild hyperkalemia, he will have only tented T waves. He can have even P wave changes also, QRS changes also. That's me. So the concentration of potassium doesn't correlate with the ECG changes. That's why if there are subtle minor ECG, minor potassium concentration changes, for example, if the potassium is between 6.5 to 7, also you should take ECG in these patients, because potassium potassium concentration change does not correlate. They are not directly proportional to the changes in the ECG. Yeah, the patient can have mild hyperkalemia and you can see sine wave pattern. That's why you should take ECG in every patient with potassium abnormality. Now these are the changes in hyper, because before going to the calcium changes, you see here how to calculate the QT interval. You start at the starting point of Q wave and you will go, this is the P wave and this is the U wave. You will draw a line like this and horizontal like this. So where they intersect, no, you draw a straight line there, and that will be the QT interval. That will be the QT interval. But most of the modern ECG machines, they will directly give the corrected QT interval nowadays. So no need to do all this, just to show this one, how to calculate QT interval. Okay. So these are the potassium changes. See here, this is a ECG of hypocalcemia. So that means QT should prolong. So here she corrected QT is prolonged more than 0.5. It is more than 500 milliseconds. So remember in the previous, in some video I said, it was there in the notes, that if the QT interval is more than 500 milliseconds, so the susceptibility to torsades deponent is very much increased, very much increased. Okay. And here you see this is ECG of hypercalcemia, and you can see the QT interval. It is 0.35 shortened. So normal range of QT interval is 0.35 to 0.46. You can remember 0.36 to 0.46. 0.36 to nothing but 360 milliseconds to 460 milliseconds. Adult, it varies according to age, but general thing in adults it is 360 milliseconds. If it is less than 360, then that is a shortened QT interval, and if it is more than 460, or some book says more than 480, it is prolonged QT interval. Okay, and this is an ECG of normal QT interval. Okay, that's about hypercalcemia and hypocalcemia. No need to calculate this corrected QT interval, because nowadays all the modern ECGs, they mention this QT interval in milliseconds. I have not shown the ECG of hypokalemia. Here you can see the ECG of hypokalemia. See here, prominent U wave is the earliest sign of hypokalemia. The thing is, repolarization is prolonged. Okay, repolarization is prolonged. So see, you can flat T waves. Here you can see, appreciate flat T waves, and here you can see prominent U waves, and flat T waves. Earliest sign of hypokalemia. Okay. Then we will see some different ECGs. The second topic will be drug effects and autonomic tone. Digitalis effect. So there will be shortened QT interval, and there will be characteristic downsloping scooped ST depression. What is the mechanism? Enhanced vagal tone and delayed repolarization. Delayed repolarization is the thing. So remember, scooped ST depression. So this Digitalis effect will have some sine in the ECG. Two types of sine can be there. Scooped ST segment like this, like a scoop, okay, or this is also known as Salvador Dali effect. We'll know in the next image. Salvador Dali effect. So this was actually, Salvador Dali is the name of a person, of a famous painter, Spanish painter, who used to keep his mustache like this. If this is a nose, like this, like this mustache. So because of this mustache, no, this scooping, that sign, that name is derived. I will show that. Okay. So remember, these two patterns will be seen because of Digitalis effect, not Digitalis toxicity. Remember this one. These signs are of Digitalis. The patient is taking Digitalis. That's the these ECGs show that thing. The patient is on Digitalis, not sign of Digitalis toxicity. So one thing is scooped ST segment. The second thing is reverse tick sign. So whenever you tick, you will tick like this, no? So the what is reverse tick? It is like this. This is reverse tick. So you can see the reverse tick sign. So these are the two types of signs you will see in the ECG and Digitalis effect. See here. This is the person known as Salvador Dali, famous Spanish painter. See his mustache. He used to keep this mustache. Because of this name is derived. See the same morphology. It is like this, scooped, like a spoon. Okay, spoon shaped. So this is the sign of Digitalis effect. Okay, then we will move. So what are the early signs of digoxin toxicity? Remember, The earliest sign of digoxin toxicity are GI side effects. GI signs. What are the GI signs? Anorexia, diarrhea, abdominal cramps, nausea, vomiting. These are the earliest sign of digoxin toxicity. Remember this point. And if you want to remember the early signs of digoxin, you can remember this mnemonic: bad van. For B for bradycardia or tachycardia, both we can know. A for anorexia, D for diarrhea, V for visual disturbances, A for abdominal cramps, and for nausea. That means mainly GI effects you will have, and next you will have eye effects. Mainly GI effects you will see in digital eye effects. Okay, that is nothing but visual disturbances. And bradycardia or tachycardia, both you can have heart effects. Bad van. Okay, so this is an ECG of digitalis toxicity. You are seeing tachycardia here. 100 beats per minute is approximately the rate of ECG, but you can appreciate if you see the lead 2. This is the Salvador Dali scooping. Okay, ST segment. This is the QRS complex. This is the QRS complex. This is the ST segment. Okay, this is the QRS complex. This is the ST segment. This is the QRS complex. But see the ST segment, it is there like this. Okay, this is an ECG of digitalis toxicity. Digitalis toxicity. It can be bradycardia or it can be tachycardia. Okay, so now we will see some other things. QT prolonging agents, you will see QT prolongation, and there will be increased risk of torsidas depointage. Which class of drugs? Class 1A antiarrhythmic Vaughan-Williams classification. If you remember, quinidine, example quinidine, and procainamide is also one there. Okay, class 1A, not it is 1C, so it is 1A quinidine, and class 3. So class 1A and class 3 like sotalol, amiodarone, they are potassium channel blockers. No, so they are potassium channel blockers, and this is sodium channel blocker. So they will prolong the QT interval. Okay, sodium channel blocker and potassium channel blocker. So these two will cause QT prolongation. Okay. Then when there is increased sympathetic tone, there will be tachycardia, short PR and QT, upsloping ST dependency. Upsloping, it is a benign sign commonly seen in tachycardia, seen with stress, exercise, or adrenergic stimulation. Increased parasympathetic tone. So you see this in athletes or exercising individuals. Okay, so conditioned individuals they are known as. So in these individuals there is parasympathetic activity is raised, so vagal predominance will be there. That's why you will see bradycardia, and that will be sinus bradycardia, prolonged PR interval, upsloping ST elevation in V1 to V3, common in athletes. Upsloping ST elevation, prolonged PR interval, bradycardia, because of conditioning, because of increased vagal tone. Next thing, this I have explained in the topic of differential diagnosis of T-wave inversions, symmetric. So profound QT prolongation, deep symmetric T-wave inversions you can see in any cerebrovascular event like subarachnoid hemorrhage, intracranial hemorrhage. Okay, so you see some ECGs here. Okay, so see, this is hypokalemia. We have seen this. So this is an ECG of hypothermia. This is known as Osborn wave. Osborn wave. What is Osborn wave? It is a hump at the J point. Humping at the J point is Osborn wave. Slurring at the J point is early reproduction pattern. And presence of a J wave is nothing but early reproduction pattern. Slurring, J wave, and differentiate between these three. This is not slurring, and this is not a J wave, nothing like that. That is of early reproduction pattern. This is just humping of the J point. Humping of the J. This is known as Osborn wave. Very rare to see, but you can see this is a characteristic feature of hypothermia. Next, amiodarone toxicity. So what you see, there will be QT prolongation and widened T wave. You can see T wave are widened, and there is prolonged QT interval. Prolonged QT interval. How much it is prolonged? Let us see. This is 3, this is 5, and this is again 4 or 3. 4 plus 5 plus 3. So 8 plus 12. So 12 small squares. 12 small squares. Okay. 12 small squares mean 12 into 0.04. 12 4 is 48. 0.48 seconds. That is nothing but 480 milliseconds. And this is not corrected. It is QT interval. Now if you calculate corrected, it will be more than 40 milliseconds. That's why, that means it is. So how you will calculate? So you take this QT interval in seconds, so it will be 0.48. So just we will calculate 0.48 seconds divided by square root of RR interval. RR interval again in terms of seconds. So these are approximately 4 boxes. 4 into 0.2, 0.8 milliseconds, zero point 0.8. So if you square root this, it will be some 0.48 to 0.87 like this, and it will become more than 500 milliseconds. 500 milliseconds. Okay. So you remember QT interval will be generally, it will be lesser than QT corrected QT interval. It will generally lesser than QT corrected QT interval. It is not in the book. It is my observation, just my observation. As you can see here, see here, QT is 0.26 and corrected is more than that. QT is 0.36, corrected is more than that. QT is 0.48 and corrected is more than that. So that's why I said if QT is 480 milliseconds, QT will be more than 500 milliseconds. So that is prolonged QT interval. So tricyclic overdose. See, you are seeing, oh, I said one thing wrong there. Okay. So in hyperkalemia, you will have tall T waves. And here you can see broad QRS complexes and shortened PR interval. No, approximately no P waves, flat P waves, shortened PR interval, broad QRS complex. Tachycardia is also there, but you are not able to see peak T wave. So this peak T wave differentiate between severe hyperkalemia. How do you differentiate severe hyperkalemia? Always differentiate between severe hyperkalemia from TCA overdose, because the ECG will be same. There will be flat T waves, there will be increased QRS width, and T waves will be large but not that large, and there will be tachycardia. This is a triad of TCA. What is the triad of TCA? Triad of TCA. Triad of TCA. Number 1, tachycardia. Number 2, increased QRS width. Number 3, okay, flattened, decreased PR interval you can take. Okay, decreased QR, sorry, I'm very sorry, increased QRS width and tachycardia and increased QRS interval, actually increased QRS interval, QT interval. 3 things: QRS width is increased, QT interval is prolonged, third, there will be sinus tachycardia. So these are the 3 things: triad of tricyclic, triad of TCA overdose. Okay, this is the triad of TCA overdose. You should differentiate. This looks like differentiate from severe hyperkalemia, because there also you see QT prolongation, increased QRS width, tachycardia, everything will be there, but peak T waves will be not there in TCA overdose. Okay, this is already I have explained this thing: cerebral T waves, inverted T waves. Okay, gigantic in the chest leads in patients with some cerebrovascular event. Now the third thing I have to explain is this one. So this will last, it will take time, nothing, don't need to worry, let it take its own time. So I'll take this one upside. See here, low voltage QRS complex. What is low voltage QRS? Less than or equal to 5 mm in limb leads, height less than or 10 mm in precordial leads, where you see this dampening in case of pericardial effusion, pleural effusion and COPD. Most commonly in pericardial effusion you will see. Okay, pericardial effusions you will see, or in case of infiltrative diseases like amyloidosis, hemochromatosis, hypothyroidism. Electrical alternans, beat to beat variation in PQRST amplitude and axis, often accompanied by sinus tachycardia. This is highly specific for pericardial effusion with tamponade. So this is, you can see in pericardial effusion, but if you are seeing electrical alternans, that is highly specific for effusion with tamponade, seen in large effusions causing cardiac swinging. So massive cardiac pericardial effusion, you may see this electrical alternans. If it is not massive, you will see low voltage QRS complexes, but you will not see electrical alternans. That is important. Okay, now we will see these things. See this ECG. I will take this downside. Okay, see this ECG. Generally, you are seeing decreased QRS complexes size less than 5 mm in limb leads. Yes, it is less than 5 mm limb leads, and less than 10 mm in chest leads. Of course, it is less than 10 mm chest leads. Okay, so widespread QRS dampening is there. Now we should rule out whether there is whether it is massive. Yes, you can see this QRS is less in amplitude and then this, and again less and then more. Why this is happening? So because of more and more fluid here in the pericardial cavity, the heart will swing in the, it will come here and it will go back, come here and go back. If there is lead somewhere here, when it comes here, the QRS will be increases, and when it goes away from the lead, it will have some decreased amplitude. Because of the swinging of the heart in massive pericardial effusion, this electrical alternance will occur. Okay, here also we can see. So that means the patient is having massive pericardial effusion with cardiac tamponade. So you can see here the sinus tachycardia is there, low QRS voltages, electrical alternance, best seen in V3 and V4. This triad is highly suggestive of pericardial effusion, usually with tamponade physiology, but is of limited sensitivity. So sense means it is not present, but if it is present, then definitely that is there, tamponade is there. False negatives you can get, false negatives. Okay, that means low sensitivity means they may not be present always, but if they are present, then definitely that is there, that is specificity. Okay, so electrical alternance. What is the triad? Sinus tachycardia, low QRS voltages, and electrical alternance is the triad of cardiac tamponade in ECG. Whether there is tachycardia, yes, 100 beats per minute is the rate. Okay, same thing explained in this ECG. You are seeing here a patient with an X-ray here, you see, and you can see the electrodes. That means the patient is lying on the bed and the shadow of the heart is very much large. Okay, and you can see the scapula also, border of the scapula. So which view is this? Whether this is PA or AP? So this is AP with chest X-ray. Okay, these are the hints for AP wave. Of course, in the AP wave, the heart appears large, but if you see in this ECG, it is very much globular in shape. Okay, cardiomegaly is obviously present in this ECG. How do you say cardiomegaly? If you calculate this distance with the maximum chest distance, the ratio should be more than 50%. So obviously it is there. Okay, so there is obvious cardiomegaly. Again, you can see there is blunting of costophrenic angle. That means there is effusion also, and silhouette sign also you can see. The border you are not able to appreciate here. Hard border you are not able to appreciate. Silhouette sign also. Probably there can be again you can see this effusion like this. Okay, so there is effusion in left-sided effusion. Along with that, you are seeing silhouette sign. Probably there can be pulmonary edema or consolidation like thing, something. I think. Okay, cardiomegaly is definitely there. Why the cardiomegaly can be due to dilated cardiomyopathy or some cardiomyopathy, or it can be due to pericardial effusion. So ECG is taken from this person. So what you are seeing, triad of you are seeing electrical alternance. So that means there is massive pericardial effusion in this patient, and I think that effusion is because of heart failure, early heart failure, pulmonary edema with effusion. You are seeing left-sided. Okay, cardiogenic pulmonary edema, that is. And if you calculate the heart rate, it is approximately 100 beats per minute. And you can see generalized dampening of the QRS complexes. Okay. The last topic is stress testing. So what is stress testing? Stress testing is nothing but it is a prognostic tool for coronary artery disease. Okay, prognostic tool. So what you see here, you see whether the patient is high risk for coronary artery disease, and if it is present, what is the severity of the coronary artery disease, you can know by this stress test. So usually it can be pharmacological or by exercise test. That is known as treadmill test. Pharmacological, you give some adrenergic cardiac stimulators and the heart rate will increase and you will take the ECGs. That is pharmacological. Here you will make the patient run on the treadmill, and during that run you will obtain different ECGs at that time in stages. Okay, so there are different protocols. The commonly used protocol is the Bruce protocol. What you will do in this Bruce protocol, every 3 minutes what you will do, you will increase the speed of the treadmill and the tilt of the treadmill, the angle of the treadmill. So initially it will flat and the angle will increase. They will increase stage by stage and they will record the ECG. So that is Bruce protocol. So when the angle increases, the patient has to walk like this, no, uphill type. So more energy, more strength is required for this. That will put pressure on the heart. Okay. So by that you will obtain ECG and you will have a conclusion based upon that result. So when it is called as positive stress test, when there is SC segment depression, so what is the endpoint? I forgot to tell. The endpoint is target is 85 to 90% of maximum predicted heart rate. What is this predicted heart rate? Predicted heart rate is calculated based on age. I'm not going detail of that. Or before this predicted heart rate, if the patient develops some symptoms, what are the symptoms? Like chest pain if he develops, or he is experiencing dizziness or syncope, or breathlessness he develops, then that will be the endpoint before this predicted heart rate. Okay, that is the endpoint for treadmill test. So positive treadmill is indicated by two things. One is ST segment changes, second one is the SBP. These two things will say whether it is positive or negative. So horizontal or down sloping more than 1 mm equal to 1 mm ST segment depression measured approximately 1 to 2 small squares after the J point is positive stress test. Other indicators are exercise induced hypertension. If the SBP drops more than equal to 10 mm, then that is severe coronary artery disease. That indicates severe coronary artery disease. So the next things are prognostic indicators. See, if these things are present, that indicates worse prognosis. Prognosis is bad in the patient. If the patient developed ischemic changes in the first 3 minutes, if there are widespread ST changes, many leads are involved. If there is sustained SBP drop during exercise, sustained drop, it is not elevating. After dropping, it is not elevating. Sustained SBP drop, or delayed post-exercise recovery. So the BP is not recovering fast, or the changes of ECG changes are not recovering fast. So delayed recovery of ST segment changes or the BP after the exercise, that is also showing a worse prognosis. Okay, then you should proceed for angiography in these patients. So these are the worst points of worse prognosis: ischemic changes in the first 3 minutes, widespread ST changes, sustained SPP drop during exercise, delayed post recovery. 4 points. Okay, that. So what are the limitations of this test? Low sensitivity, again same thing. If it is present, then definitely it is there, but if it is present, then this the changes you can't see. If it is present, so false negatives, in short, simple words you can say, false negatives are possible. And one more thing is, interpretation is unreliable if the patient has LBBB or WPW pattern in his ECG. So that in those patients the changes are unreliable. Same things here, you can see positive stress test is more than 1 mm depression, either horizontal or down sloping. Up sloping is non-specific. Okay, non-specific. Now you see, this is the last thing. This is a stress test ECG recorded on the treadmill. So you will see, you are seeing changes. See here, 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 here. These are anteroceptal leads. These are anterior leads and these are lateral leads. See, this is the lateral lead, this is the lateral lead. One AVL, V5, V6, V2, V3, V4, V5. That means anterolateral leads you are seeing ST segment depression. See here, it is given ECG recorded during an exercise treadmill test showing anterolateral ST segment depression after 3 minutes of exercise using the Bruce protocol. So widespread means the anterior leads are also involved, the lateral leads are also involved. That means this patient, the prognosis is worse. Okay, the 4 points. Widespread ST segment depression indicates worse prognosis, and less than 3 minutes if one is having ECG changes, that's also a bad prognosis. And if he develops, if his BP is dropping and not recovering during the exercise, that is also a worse prognosis. And after the exercise, if he is recovering very late, that is also a worse prognosis. So here we can see widespread because two regions are involved except to the inferior leads, anterior and lateral part of the heart are involved. So we can see the patient should go angiography. That's about all about the ECG till now. Okay, so from next video onwards we'll be discussing a new topic. Thank you.